I've been on call at the hospital for the last week, one of the trauma centers in our community, and we've had some patients come in with head trauma and brain injuries. And I wanted to talk just a little bit about some things that I think patients should understand with regards to what we are doing to manage a head trauma. There's two general categories of injury to the brain in head trauma. One is primary injury and the other is secondary injury. Primary injury occurs at the moment of impact. It's neurons and cell bodies and their axons that are injured when the head is injured and the brain is injured. And sometimes we refer to that as shear injury or diffuse axonal injury. We can't do a lot to repair that type of injury, and we'd be looking at more of a rehab situation to try to reform connections in the brain and relearn things. Most of the injury that we deal with in the hospital is to manage secondary injury. So secondary injury would happen after the accident. Perhaps the brain swells and blood flow is not adequate to certain parts of the brain, and the patient suffers a stroke, for example. Or there's a blood clot in the brain and it shifts brain tissue over, and that brain tissue is affected by the blood clot. Swelling is one of the main things that we deal with in the ICU, and we have some ways to manage swelling. One way that we manage swelling is to raise the patient's head of bed up so that blood can get in, but also readily drains. Another way is we give the patient some sedation so they're nice and calm and relaxed. We can give the patients 3% sodium or mannitol. And what that does is it, in a way, dehydrates the brain. The sodium and the mannitol in the bloodstream pull fluid from the brain into the bloodstream so the brain gets dehydrated in a way. Another thing we can do is drain spinal fluid. So sometimes we'll put a drain into the brain and drain the spinal fluid. We can give the patients a paralytic agent so that the patients at that point would need to be intubated, but so that they're not moving and not aggravated. And then we can go in surgically and remove blood clots and other kinds of mass lesions, if you will, to alleviate the pressure. The brain is in a fixed compartment. The skull does not expand. It doesn't get any bigger. If the brain swells, it doesn't have anywhere to go. In some cases, we can remove the skull. And this comes up from time to time where we have a lot of swelling and we're not sure, or we're not able to get full control of the swelling. The question is, should we remove the skull to accommodate the swelling? I have some mixed opinions and feelings about that surgery. The data shows that if we cannot control the swelling, about 50% of the patients don't survive the injury. If we take the skull off, about 30% of the patients don't survive the injury. So we've saved about 20% of the patients. However, those patients that survive tend to have significant disabilities with activities of daily living and need a lot of additional care. So these are some things that I hope patients and their families can recognize and understand with regards to head injury in the ICU setting. We have some limited therapies that we can do to manage the swelling. In extreme cases, we can remove the skull, but if we do that, the patients are more likely to survive, but may also be significantly impaired from the head injury.